Okay, well, it looks like our attendees are leveling off and getting into the room, so we're going to go ahead and kick off tonight's talk, Pelvic Organ Prolapse. We welcome you to the virtual talk series as a way of continuing to provide you with the healthcare information you need at this time when we need to keep socially distanced. If you haven't yet joined us for a health talk, many of you may have. I'm just going to go over some of the quick housekeeping details for you. Tonight's talk by Dr. Joseph Wells Henderson will be a presentation followed by a question and answer. And at the bottom of your screen, you will see the Q&A button. This is where you'll type your questions that Dr. Henderson will later answer after the presentation. If you so choose, you may select an anonymous button within the Q&A, so your name will not be posted. To also let you know, this talk is recorded and it will be posted on our website. Once it's posted on our website, you will receive a link. Everyone who registers for the talk will receive a link. You can go back and watch it or share it with friends or let people know that weren't able to attend live today, that they can go back and watch it then. So without further ado, I'd like to introduce Joseph Wells Henderson. He is a part of the Department of Urology in the Division of Female Pelvic Medicine and Reconstructive Surgery. I'll hand it off to Dr. Henderson.
Good evening, everybody. Hopefully you can hear me all right. And if not, just turn up your volumes, please. But tonight we're going to be talking about pelvic organ prolapse. There's a bulge. Again, I'm Joseph Wells Henderson. I am a gynecologist by trade, but employed by the urology department and am a specialist in female pelvic medicine and reconstructive surgery. So without further ado, we will advance here. So I have no disclosures. No one is paying me to talk about prolapse, and I don't have any industry sponsors to date. So who am I? Again, I am a specialist in what's called female pelvic medicine and reconstructive surgery. In the past, we used to be called urogynecologists, but they decided to rebrand us about 10 years ago. In order to be a urogynecologist, you do 3 years of post-residency training. So you can access this specialty through urology or through gynecology. We're dedicated to the care of women with disorders of the pelvis, from incontinence to defecatory complaints to prolapse, pain, etc. And really, we set the standard for care and excellence in the female pelvis. We are discreet, sensitive, and caring because of the sensitive nature of these issues. And I hope that you'll trust me with my words tonight. And hopefully, if you have any questions or concerns, you'll be comfortable asking them at the end of the talk. Specifically, I graduated from college back in 2000 from Harvard, did medical school at Jefferson. Worked out west in Utah for my residency, and was out there for an extra year working just as a professor. And I did my fellowship here at university hospitals and Metro Health, and then was asked to join the faculty here, and have been here ever since 2017. Live in Shaker. 3 kids, 2 dogs, and I work between the university hospitals, Bedford Medical Center in Richmond, and also have some space down at Cuyahoga Falls. So without further ado, I feel a bulge down there. I must need surgery. This is pelvic organ prolapse. This is a very common finding on routine examination. I see a number of patients who come to my clinic saying, I don't feel anything going on, but my doctor said that there's a bulge down there. This is typically asymptomatic. You don't have symptoms. And up to 80 to 90% of women who have completed childbearing have some degree of weakness in the vaginal walls on examination. The Women's Health Initiative was a very large study looking at the effects of estrogen, the effects of is a very large population-based study. And from a symptom standpoint, about 40% of patients had symptoms of prolapse after the ages of 50. Basically, the prolapse or the weakening can involve any compartment of the vagina. So when you think of the vagina, there's the front wall where the bladder sits. There's the top of the vagina where the uterus would be or would have been removed after a hysterectomy. And then, of course, the back wall, which is where the rectum sits. And if there is weakness in one, there can very generally and commonly be a weakness in one of the other areas as well. Patients will present, if symptomatic, with complaints of a bulge or heaviness or pressure, feeling something down there when they wipe. Now, this may affect issues with urinating. It may affect issues with having a bowel movement, with defecating. And some patients sometimes need to reduce this bulge, place their fingers vaginally to push the bulge back up inside in order to feel like they completely empty their bladder or completely evacuate their bowels. However, at no point will pelvic organ prolapse cause diabetes, cause cancers, cause strokes. At no point will it progress to evisceration. So at no point will that bulge rupture and bowels or bladder or something else will come out. At no point, 100% of the time, okay? However, it may cause discomfort. It may cause, like I talked about a second ago, obstructive urination or defecation, needing to reduce that bulge in order to have a bowel movement or urinate. Sometimes it worsens these lower urinary tract symptoms. I feel more urgency, I feel more frequency because of this bulge kind of being in the way. Furthermore, you can think of that bladder, which is a muscle, being kind of stretched down into this bulge, and muscles don't like to be stretched, they like to be relaxed. So it kind of can spasm. There's an element of embarrassment, not wanting to talk to anyone, not going out, feeling uncomfortable, not having intercourse because of this concern, and significantly adversely affecting the quality of life. This is kind of a confusing drawing, but just to get you an idea of how complicated the support of the female pelvis is. So the image on the left-hand side of the screen shows you looking down into the pelvis, that the front wall, the front area is where that bladder sits. The middle is where the vagina is, where that cervix should be, or if you've had that hysterectomy, where the top of the vagina should be. And then in the back, that rectum. And all of these ligaments and support structures are there to support the rectum, support the bladder, support the vagina into where it's supposed to be. Similarly, on this lateral view on the right-hand side, you can see from the side how these ligaments can insert both into the spine and into the pelvis to help with that support. Meaning that if there's any abnormality in the support, it can happen in a number of different places, both kind of from the top down to the side to side. So pelvic organ prolapse, we use clinical complicated terms to describe this. A cystocele is what many people refer to as a dropped bladder. Now, I try and tell all of my patients that they do not have a dropped bladder. What they have is a weakness in the front wall of the vagina. The bladder is an innocent bystander. It sits on that vaginal wall. When that front vaginal wall has lost its support and it drops, the bladder drops with it. Similarly, on the back wall of the vagina, if you have a weakness towards the opening of the vagina, which you'll see in the over here on the rectocele, you can have a weakness in the back wall of the vagina, allowing the rectum to push into the vagina. That's kind of a dropped rectum. It is not a rectal prolapse. That's different. This is a weakness in the wall of the vagina, meaning that the rectum is pushing into the vagina and giving that sense of bulge. Similarly, the top of the vagina, if the uterus is dropping, that cervix can come out. You can have a dropped uterus. And finally, if there is no cervix, is no uterus, if the patient has undergone a hysterectomy, you can have the vault of the vagina, those tissues of the vagina, no uterus at the top, that can drop. Okay, that's a post-hysterectomy vaginal vault prolapse. Now, these are some kind of scary images, but this is what patients will see. This is what I see on exam. So you see a bulge, you feel a bulge. Sometimes this bulge can easily be pushed inside. Sometimes it's very uncomfortable to be pushed inside. The issue is that seeing these pictures, it's very hard to tell what kind of prolapse is going on unless you are being examined. Is this just the front wall? Is this just the back wall? Is this the top, or is it some combination thereof? Okay. Risk factors for prolapse involve genetics. So if your sister has this, if your mother has this, if your daughter has this, you have a much higher likelihood of developing this. Race, so Caucasian, more likely to have prolapse than African American versus Asian. History of a vaginal delivery, at least one increases your risk of prolapse, but just being pregnant is a risk factor for prolapse, with a C-section or not. Any type of gynecological surgery, so if you've already had a surgery for prolapse, your risk of recurrence, your risk of prolapse is very high. Similarly, smoking degrades some of the tissues vaginally and can harm some of the tissues vaginally. Chronic cough, obesity, constipation, those things that are putting chronic constant pressure on that pelvic floor can put you at risk. And finally, the older you are, the higher the likelihood is for developing prolapse. However, I want to be very clear, pelvic organ prolapse is not, and I repeat, not a normal part of aging. It is a disease. Whether it's symptomatic or not is a different matter. So when it comes to the vaginal delivery, many patients come in and say, I had a C-section. I don't know how I could have developed this type of prolapse. Well, the truth is that it just has to do with the pressure of pregnancy that can cause this prolapse. So there was a great deal of talk a number of years ago about whether we should just be C-sectioning everybody to prevent some of these deleterious effects of a vaginal delivery with incontinence, with prolapse, but it's not that clear cut. So how is it diagnosed? So number one, the most important part of this is a physical exam, okay? If you feel something there, I want to be able to tell you exactly what that is, knowing if it's the front wall, the back wall, the top, some combination thereof, okay? And the way that I describe this to my colleagues and the way that I kind of know where these weaknesses are is through this thing called the POPQ, pelvic organ prolapse quotient. And there's 6 different points in the vagina that I'm measuring on exam so that when I talk to a colleague, when we talk about the therapeutic options, we have a starting point. So we know where you were so that we can talk about where you want to be and where you will be down the road. In terms of prolapse, people will talk about the stages of prolapse. Stages are much broader. They don't really give you the finite detail of the POPQ exam. So stage 0, again, no prolapse, that all of those points in the vagina are where they're supposed to be. Stage 1, the prolapse, that bulge, is still within the vagina, okay? Stage 2, the area of that bulge is just at the opening or 1 centimeter just beyond. Now, stage 3 is greater than that 1 centimeter from the hymen, but not everything. And then, of course, stage 4 is complete eversion. That's what we call procedentia. That's where the entire vaginal vault, potentially the uterus as well, has completely everted and come out of the vagina. So when do I need to do something? Well, when it comes to needing to do something, a medical reason that the white coat tells you that you need to do something, it really comes down to urinary retention and defecatory obstruction. The reason being is that if the urine is not emptying appropriately, that pressure backs up and can harm the kidneys. Okay, so we need to improve the prolapse to improve the evacuation of the bladder. Similarly, with bowel obstruction, if there's defecatory obstruction, you can harm the colon. And so we need to improve the anatomy to improve the evacuation. But the number one reason to do something about prolapse is bother. It is bothering you, the patient, meaning that you feel uncomfortable. This is impacting your quality of life. You are not able to do the things you want to do because of this bulge. That is the reason to do something about it. So, what about treatment options? Starting kind of from the least to the most, we'll talk about these options. Number one is observation. Number two, physical therapy. Three is something called a pessary or pessary placement. And finally, surgical repair. When it comes to observation, if there really is no bother, no retention, observation is a great safe option, okay? Hey, my doctor told me this was there. Hey, I have this. I want to be reassured that this isn't cancer, that this isn't something else going on. Observation is something that is safe. About 50% of patients, about half of all patients coming in with that first diagnosis, that first sensation of prolapse, will keep that degree of prolapse after a year. That being said, half of the other people will have some degree of increasing prolapse. Now, that doesn't mean symptoms. It means that the prolapse itself can get larger with or without a change in symptoms, okay? However, the most important thing is to remember that observing the pelvic organ prolapse, that there's no increased risk of developing cancers or other medical comorbidities with observation. It's a very safe option. The next option is physical therapy. So within the American Physical Therapy Association, there are a group of women that have been specially accredited to do something called pelvic organ prolapse, it's called pelvic floor physical therapy. Now, these therapists are the best of the best. I've never met a bad pelvic floor physical therapist. They do a number of different therapies with the patients, something called biofeedback, working on the strength of the pelvic floor, relaxation, internal manipulation. And the idea is that they can give you, the patient, these tools, these tricks, these techniques to work at home and to work on that strength of the pelvic floor to improve that support of that pelvic floor. However, the caveat here, the thing to remember is that if that prolapse is beyond the opening of the vagina, beyond that hymen, unfortunately, the prolapse will not be reduced, will not be improved with pelvic floor physical therapy. I know this is recorded and you'll be able to access this later, but this website here, this Women's Health APTA, American Physical Therapy Association, is a great way to find a pelvic floor physical therapist near you. So Kegels really do work, but there does become a point where beyond that opening, if that prolapse has progressed beyond that opening, Kegels aren't necessarily going to make it any better. The next option is something called a pessary. This is what pessaries look like. There are a whole bunch of options underneath the sun. This is what one looks like here in the package. They're soft, they're malleable, they're made of a silicone and a plastic, easy to clean, very, very safe. The idea with a pessary is that it is a permanent, non-permanent solution. And what I mean by that is it's something that patients can try with minimal to no risk. So with these different shapes and sizes, the idea is to get fitted. It's placed through the vagina, and it can treat both prolapse, that bulge, as well as something called stress urinary incontinence, which is that laughing, coughing, sneezing, leaking. About 50 to 60% of patients, if they're successfully fitted with a pessary, will continue it after a year. Now, glasses half full, glasses half empty. That means that 50 to 60% of people won't need to go on to these more advanced therapies we'll talk about in a second, that they can be comfortably, safely managed with minimal risk, okay, for as long as they want. Again, at any point, a pessary can be removed or replaced. The idea, though, is that this is something that does need to be chronically managed. So about every 3 to 5 months, the pessary needs to be removed from the vagina, cleaned, a brief exam, and replaced. Many patients can manage their pessaries at home if they only want to use it when going out, if they're only using it during intercourse, if they're only using it at certain times. This is something that can be safely managed at home. But most patients really want an option that is out of sight, out of mind. The question that many people will ask me is, well, how do I know if it's working? Well, you're going to tell me that it's working. You're going to be satisfied with it. The idea is it is serving one purpose and one purpose only, that is to improve your quality of life. And if it's not doing that, well, then out it comes. The last options, the most definitive options, are surgery. And there are a number of different surgical options depending on various risk factors and goals of the patient. There are vaginal surgeries, they're laparoscopic, using these small incisions on the belly, as well as open transabdominal surgeries. There are lots of different materials that can be used. We can use different stitches, sutures that dissolve over 6 to 8 weeks. An allograft is a fancy word for a human tissue graft, your own tissue graft. There's a xenograft, there's porcine, there are pork products out there, and there are also mesh products. So just like we use mesh for hernia repairs in the abdomen and so forth, we have safe mesh products for the vagina as well. Now, I'm sure that people will be asking questions later about transvaginal mesh kits. I will kind of say very briefly that the FDA correctly removed them from the market about 4 years ago. We do not use them anymore. So when I speak of mesh, I'm speaking of a very specific kind of mesh that we'll talk about in a second. But the variations of the surgical techniques, the types of sutures, the types of materials, all come down to and all play into the durability of the procedure and really the goals of the procedure. Now, all of these surgeries can be performed with or without a hysterectomy. Similarly, those patients that have already had a hysterectomy, these are surgeries that can be that are applicable as well. Now, most importantly, the goals of surgery are to maintain the sexual activity, if that is important. Most importantly, it's improving that sense of general health, getting you back to doing the things that you want to do, how you want to do it. When it comes to surgeries, there is a recovery period, and we'll kind of talk about those restrictions during the recovery period. But the idea is that after you heal from that surgery, there shouldn't be any restrictions. You can ride your bikes, you can go for long walks, you can have intercourse, you can lift things, you should be able to get back to doing everything that you want to do, and maybe some things that you don't want to do. But the goal is to fix it all. So wherever there are weaknesses, to repair that at the time of surgery, okay? Now, the issue with the surgeries is that they are not 100% effective, meaning that there is, depending on the surgery, always a risk of recurrence. Now, those risks are low, but they are not zero. What I can say is that typically speaking, when it comes to pelvic reconstructive surgery, that about 8% of patients to 10% of patients will return to the operating room for a second procedure, second surgery after their first surgery. But when it comes to success, there are lots of different ways to look at that in terms of symptom relief, in terms of sexual health, in terms of urinary. These are effective surgeries, but again, there is the risk of prolapse recurrence. Now, one type of surgery is something that's called a sacrospinous ligament suspension. Again, this can be done both with and without a uterus in place, and it utilizes this very strong ligament that goes from the spine of the pelvis to the sacrum. You'll see this little white ligament here. And through a very small specialized instrument, these dissolvable sutures are placed through that ligament to lift the vagina back up to that area. Okay, now you look at this picture and say, well, my vagina is going to the right. Yes and no, that's not, you don't feel that sensation, but the reason it goes in that direction, the reason why I typically do it in that direction is to remove any kind of risk of getting into the rectum, because that rectum is coming down right through the middle here, remember. Very safe, same-day operation. It usually takes between an hour and a half. And again, we're going to talk about all the restrictions in just a second. There's also something called a uterosacral ligament suspension. We like to keep it simple for us docs. So a uterosacral ligament, it goes from the uterus to the sacrum, is this ligament. And using these little sutures, again, that can dissolve on their own, can lift this vagina, this top of the vagina. You'll see the bladder up front and the rectum and behind. You can place these sutures through the top of the vagina up through this ligament to lift that vagina back up to where it's supposed to be. This is a surgery that happens with mesh. Again, this is something that we've been doing for greater than 40 years, and we've got very good data on it in terms of its safety. Again, I said I would mention it, but the transvaginal mesh kits typically had complication rates in the 30% to 40% range. This type of surgery has the risk of a mesh complication erosion of about 2%. So apples and oranges, very different. But what this is doing is, with this Y-shaped mesh on the front wall of the vagina and the back wall of the vagina, lifting that vagina back up to this very strong ligament that's on the inside of the abdomen. It's running down the front side of the spine. It's not involved with the spine, but that's just where it sits. And using these sutures, lifting the vagina back up, helps reinforce the tissues of the vagina. The idea with this colpopexy, this sacrocolpopexy, is that especially in those patients that have had recurrence, in those patients that have very significant disease, we believe that this surgery is the most durable of the options out there. This is what it looks like from the side to kind of get you an idea of that mesh kind of wrapping around the vagina and lifting up to this very strong ligament that runs down the front wall of the spine. Finally, the most definitive surgery out there is something that's called a Lefort colpoclesis. This is one of the oldest surgeries that we actually still perform in medicine. We've been doing it for greater than 130 years, if you can believe it, and haven't found a way to do it any better. This is a surgery that is excellent for those patients that have significant prolapse and are not thinking of becoming sexually active, okay? The reason being is that because it really does close up the vagina. So externally, the vagina looks totally normal. The clitoral hood, the opening of the vagina, the area between the vagina and the rectum, everything looks normal, but the vaginal depth is significantly reduced to about 1 to 2 centimeters. I said that none of the surgeries are 100% effective. This surgery is as close to 100% effective as we can get. And the wonderful thing about this is again a same-day surgery, takes about an hour to an hour and a half, not entering the abdomen. My oldest patient having performed this was 94, she's 96 now, doing great. So it's a great, safe option for those patients, again, who are not planning on becoming sexually active and have a very large degree of prolapse. It can be done both with a uterus in place or without. So, final thoughts. Don't fix it unless it's broken or bothersome. This is a safe thing to watch if you're not being bothered by it. But if you are, that's the #1 reason to do something about it. Conservative therapy is first line. The best thing to do is go low, slow, okay? We do these little things that have the least risk and potentially the most benefit before we need to do something invasive. And finally, when it comes to surgery, when it comes to those definitive surgical options, we do have great minimally invasive options and ever more coming through the pipeline. So I wanted to thank you all for tonight's talk. If you're interested in following up with myself or with one of my colleagues, you can take a look at that telephone number, and I'm happy to answer any questions that you may have. I think that Mark is going to help us with those questions.
Yes, thank you, Dr. Henderson. Again, if anyone has questions to ask, please submit them at the bottom of your screen. You'll see the Q&A button. If you enter your question in there, I will read it for Dr. Henderson and we'll get those questions answered for you. We did have one come through so far, and we'll start off with this person asks, my colon has a bend in it from having large babies, and my bladder is resting next to my colon now. I had bladder repair surgery 35 years ago. Apparently it has come loose. A pessary did not work for me. It fell up before I got home. What can I do next? She's in her 70s.
Sure. Yeah. So there are a lot of questions that I would need to answer. So it sounds like there's probably been a hysterectomy. If the pessary didn't work, again, there are a variety of different pessaries out there. Another question is, what are the goals? Is the goal to maintain sexual health or not? What is the degree of prolapse? Or is it the prolapse that's causing problems, or are there more rectal complaints and bladder complaints? So this talk is really designed just for the prolapse, but overactivity, the bladder misbehaving is its own talk that we can take hours talking about. Similarly with the bowel movements as well. Conservative therapy is usually the best. If it's a bowel-related complaints, we talk about fiber, really to bulk that stool, to allow it to have some bulk to hold on to, which is easier to pass, especially with degrees of prolapse with rectoceles. And on the front wall of the vagina, if it's really a bladder, talking about those stretches, strengthening techniques, pelvic floor physical therapy to improve the emptying of the bladder. But the issue is that when it comes to these prolapse therapies, really we've got expectant management, physical therapy, a variety of different pessaries, and then surgery. Those are really the 4 options moving forward. I hope that answered your question.
We had a couple of questions asking for the website for the physical therapy, which I've posted that in the chat, as well as answered a couple of those through the Q&A for people. So if people still
Great.
need access to it, let me know and I'll resend that.
Excellent.
Next question, someone asked, will these surgeries correct incontinence?
Great question. So again, this is sort of a prolapse talk, but when it comes to incontinence, and I assume you're talking urinary incontinence. When it comes to urinary incontinence, there are 2 different kinds. One kind is what we call stress incontinence. I laugh, I cough, I sneeze, I leak. The other kind of incontinence is what we call urge incontinence. Now, that's an oversimplification, of course, but that's kind of the general division. Stress urinary incontinence is something that has everything to do with anatomy. So it has to do with the support of the vagina, the support of the urethra. So yes, there are surgical options at the time of prolapse that can correct that kind of incontinence. Now, the urge incontinence, however, is more related to dysfunction of the way that the bladder is working. So the neurophysiology of the way that the bladder is spasming, not working. Like I said earlier, the bladder is a muscle. So in some situations, if the bladder is under stretch, fixing that stretch, supporting that vaginal wall can improve some of those urgency symptoms. But typically, prolapse surgery is not performed for overactive bladder. Okay, there are other therapies for the overactive bladder.
Great. Our next question, first ask if you could go back to the pessary images. They're saying they have one, but you're not sure if they're using it correctly.
So the wonderful thing about pessaries is that they should find their place. That it's not necessarily that they're out of place. The only things that pessaries can kind of be out of place is if you look at these images and you see the ones with these little knobs here, these pessaries are designed for stress incontinence. So those knobs will go in the vagina and sit underneath that urethra so that when you laugh and you cough and you sneeze, that little knob helps support that urethra and prevent that laughing, coughing, sneezing, leaking. But typically speaking, all these other pessaries, these gel horns here, these ring with supports, shats, rings without supports, the discs, they will kind of find their place. Now, fundamentally, like I said earlier, pessaries are designed for one thing and one thing only, to improve your quality of life. So if they're uncomfortable, if they're not working, well, we should fix it, or look for other options to give you back that quality of life that you're looking for.
Great. Our next question is, any opinion on Kegel trainers like Yarlap?
Great question. So I get a lot of questions about that. So working in university hospitals, we as physicians really try and pride ourselves on providing care that is derived from evidence-based medicine. Okay, and the problem is that there are a lot of new technologies that are coming on the market which we simply don't have that evidence for yet. What I can say is that there is no evidence out there really to support those Kegel exercise tools. And what I mean by that is we have good technologies out there. We have pelvic floor physical therapists that do amazing jobs, that we have excellent data out there to support pelvic floor physical therapy in terms of questionnaires looking at bladder function, bowel function, sexual function, prolapse complaints, pain. We know that pelvic floor physical therapy works. So what should happen is that we should get these trainers, these software trainers, and compare them. No one's done that. Mainly the reason for that is there is a very low likelihood that these trainers, excuse me, are going to be any better than a pelvic floor physical therapist. So they're not covered by insurance. They don't appear to have any deleterious effects. They're not going to hurt you. But the main question is whether they really help. And unfortunately, the data just doesn't really exist for that right now. So I'm sorry, I'm not much help.
Our next person would like to know, in your 70s, is it just time to have a hysterectomy and be done with it?
Great question. So yeah, sorry, is there more to the question?
Yeah, or is a more conservative treatment the better route? This person has some urinary incontinence, but it's not bad.
Yeah, so hysterectomy is not going to fix incontinence. Okay, it is not going to touch urinary incontinence or defecatory incontinence. A hysterectomy is something that is typically performed at the time of prolapse surgery for, like you mentioned in the question, kind of risk reduction for cervical cancer, uterine cancer, ovarian cancer, etc. But the truth is that those risks are very low in your 60s and 70s. The risks of the surgery in terms of the hysterectomy are also very low. So hysterectomy is one of the most common surgeries that we perform in the United States. And as such, we're pretty good at them in terms of safety. But there is not a point in a woman's life where she has to have a uterus removed unless there's something else going on, unless there is an increased risk of cancers, unless there's a good clinical reason to have a hysterectomy. That being said, having trained out in Utah, I'd have patients come to me in their 30s saying, I've completed my childbearing, it's time to have my uterus out. And we have to have a long conversation about kind of the goals of that, the risks of that, and the whys. But no, at age 70, you don't need to have your uterus out unless there's something else going on to make that a risk-reducing surgery or to give you some kind of clinical benefit to have it removed.
Our next question is, do you find a lot of younger patients in their 40s that are sexually active that get bacterial infections because of uterine prolapse? This person has experienced this in stage 1 of uterine prolapse, and hers is lying on her cervix. She was prescribed antibiotics for this over a year to finally clear it up, but it remains an issue with sexual activity.
So with sexual activity, so typically it doesn't have to do with prolapse. Prolapse does not increase your risk of bacterial vaginosis, yeast infections, sexually transmitted diseases, etc. What we look at during an exam is, especially in those patients who are perimenopausal, so in that time period where the cycles are beginning to change, that the tissues of the vagina begin to change and the environment in the vagina begins to change as the estrogen, as the amount of estrogen and progesterone kind of change in the vagina. And with that changing environment, the natural immunity against these kinds of overgrowth of bacteria changes. Many times it's very simple things. So number one, and patients, I'm sure we're going to get some questions about this, no soap vaginally. And what I mean by that is everywhere else in the body can get soapy, but in the vagina, the opening of the vagina, never, ever, ever, never soap. No wipes, nothing like that. The vagina does an amazing job of keeping itself clean, healthy. It produces these proteoglycans to create an environment for good bacteria to be there. The more soap, the more irritants, the more foreign materials that are placed in the vagina, the higher the likelihood that the bad bacteria are going to come in and cause trouble. Prolapse does not cause an imbalance in that, but other things can. So number one, really, if using condoms, making sure that the spermicidal that there's no spermicidal lubricant, other irritants that can irritate the vagina. Usually a pure silicone-based lubricant is the best option out there. One of the best options, easy to remember, Uber Lube. It's a wonderful, pure silicone product. But really, it comes down to hygiene. And a lot of people think, I'm dirty, I need to use more soap. And then we get caught in this nasty little feedback loop. But there are patients with chronic vaginitis that do need to be treated with low-dose antibiotics, metronidazole gel a few times a week, sometimes boric acid tablets, but it's a slightly different conversation than prolapse.
Great. The next question is, recently had a hysterectomy with mesh for my bladder. Not 13 weeks yet after surgery, having some discomfort with the mesh, and I can see a new bulge.
So again, there are different kinds of mesh. And when patients talk about bladder mesh versus vaginal mesh, really have to kind of get down to exactly what you're meaning. So there's mesh to lift the vagina. Okay, again, really the only product out there in the United States that we do that for is for this type of surgery called a sacrocolpopexy. Okay, but otherwise, The only other mesh that we place vaginally nowadays is for a sling. It's for a mid-urethral sling, and that's for stress urinary incontinence. It has nothing to do with prolapse. It does not support the bladder. It supports the urethra, but it does nothing to the bladder or the vaginal walls. So the main question really is, if you feel a bulge, is there really a bulge, and where is that bulge coming from? Because again, there are these three compartments of the vagina, and maybe that surgery only addressed one of those compartments, and it is now uncovered a different compartment where there was a weakness. So again, a sort of a good exam is really key to get an idea of what's going on.
Our next question is, would a prolapse cause sciatic nerve pain?
Good question. So no. So when you think about the prolapse, there are no muscles within that tissue. There's fibromuscular tissue, but there aren't nerves or inflammations that are being pulled and stretched that can cause sciatic pain. That being said, pelvic floor dysfunction. So you've got 5 muscles on the right-hand side of the pelvic, 5 muscles on the left-hand side of the pelvis. Prolapse can sometimes induce people to really try and hold on to that pelvic floor, and those muscles can spasm. When those muscles spasms, those muscles insert into the sacrum and into the hips and that spine, and can cause nerve pain. It can cause sciatic pain. So it's not that they're always related, but they certainly can be. But it's not really the prolapse that's causing it. It's really the muscular dysfunction of the pelvic floor that's causing it.
Our next person asks, I have a protruding bladder and presently using a pessary. They want to know how long they can continue to use that, and will they need surgery in a few years?
Great question. So pessary is something that you can safely use forever. And what I mean by that is, so long as you're continuing to have benefits from the pessary, meaning that the bulge complaints are gone, that you're able to do the things that you want to do, you can use a pessary forever and ever. The different kinds of pessaries out there require different kinds of maintenance. So most of the pessaries, and I'll show you them again. So most of these pessaries, the rings with support, without support, the gel horns, their gear rungs over here, most of those pessaries require follow-up about every 4 months, meaning that the pessary needs to be removed, cleaned, examined, and then replaced. That being said, these cubes here need to be removed every day. And many of they're rarer, but some of these kind of donuts and so forth need some maintenance more than that. But no, at no point do you need surgery. Surgery is never necessary. It's purely driven by your success of alternate therapies. So if the pessary isn't working, if physical therapy isn't working, if you're not satisfied with that, then yes, have a conversation about surgery, but it's never something that has to be done.
Our next question is, if you had a hysterectomy 3 years ago and your uterus, cervix, and fallopian tubes are removed, what happens to that empty space?
Great question. So this is anatomy, and I don't know if I have a good picture of it. Let's see. So this is kind of the picture of it. So if you look over here, if you see this vaginal vault, okay, so here we are with the this is the uterus before it's been removed, and over here is that empty space. So that area between the rectum and the bladder is gone now. So it's this kind of potential space. So this vagina here, which used to be on the inside, is being protruded down. So what's filling that space? Sometimes it's a bit of the bladder. Sometimes it's a bit of the rectum being pulled in, Sometimes it's small bowel above that's filling that prolapse. But it's not something that is worse or better than a prolapse with a uterus.
Our next question comes from a person who says they're 75 years old. They recently had a pessary for urine leakage. It started out great, but now it's a constant battle between changing sizes twice and it falls down. They put it into bed and leak all night. And she's saying that she still has urge incontinence, and their PA is saying it's because she is obese, and she's looking for suggestions.
So unfortunately, when it comes to this disease of prolapse, like we talked about earlier in terms of the risks of the disease, there are lots of risks. Obesity, chronic cough, smoking cigarettes, those are diseases which we have the opportunity to improve. Okay, we can't. It's so hard. Okay, the hardest thing that people can do is lose weight and quit smoking. But improving obesity, improving on smoking, has been shown to, in about 30% of patients, 40% of patients, to improve prolapse complaints. Now, the problem is that when it comes to a pessary, like this talk was, the pessary really is designed for prolapse. It is not designed to treat overactive bladder. It can be, like we've seen in some of these other pessaries here, it can be used successfully to treat some stress urinary incontinence complaints. But when it comes to overactive bladder, that is a different disease. Hypertension, diabetes, prolapse, urinary incontinence. These are all different diseases. There's some crosstalk, but they're not, therapies for one don't necessarily treat the other. But if the pessary isn't successful, it's not successful. Your physician should kind of give you the options of moving on, what other options are out there.
The next question is, does surgery repair rectocele, or will that pocket still exist after the vagina is listed?
So it depends. So again, the idea with that first visit is to really get an idea of where the weakness is in the walls of the vagina. So when it comes to surgery, surgery is supposed to address all weaknesses. So the apex, where the top of the vagina is, if that's dropped down, the front wall where that bladder sits, if that's dropped down, the back wall, that rectocele, if that's coming out as well. So surgery should be able to address all of those things. So if it doesn't, if there's a recurrence after the surgery, that's slightly different. But the idea is that a surgery, you should be kind of one and done. Surgery should address all of those prolapse complaints.
And perfect segue is, what are the restrictions after surgery?
Great question. I forgot to answer that. I apologize. So when it comes to restrictions, really after any prolapse surgery, 3. The most important is no heavy lifting, okay? We say don't lift more than about 10 to 15 pounds for 6 weeks, okay? The second is no bathing or soaking. Showers are typically fine, depending on any kind of abdominal incisions, just getting those dry after the shower. And 3, nothing in the vagina. But the idea is, again, at the end of those 6 weeks, you should be able to get back to doing all of those things. But during those 6 weeks, no restrictions in terms of a diet, no restrictions in terms of steps, no restrictions in terms of stairs. Once you're off of narcotics, once you're off of pain medication, which is usually 2 to 3 days, you can get behind the wheel. If you're not on the pain medication, as soon as you're walking comfortably, you can get behind the wheel of your car. But the idea is, after those 6 weeks, getting back to doing what you're doing. Thank you for that question. I'm sorry I didn't answer that earlier.
The next question is, what about a bulge that isn't always there? Excessive standing, lifting can aggravate it, sometimes accompanied by dull pain in the perineum area that does go away with short rest. Would this be a candidate for PT?
Absolutely. You beat me to the punch. That's a great physical therapy situation, because many of the kind of chronic fatigue of the pelvic floor can be significantly improved with the right type of exercises, stretches, strengthening techniques. Many times it just has to do with how you're lifting, what you're doing with the core strength to improve and prevent that prolapse from coming. So yeah, absolutely. I think physical therapy is a great place to start with that.
Someone would like to know if there are physicians on the west side.
Yes, there are. So within our female pelvic medicine and reconstructive surgery group on the west side, there's Dr. Adonis Hijaz, Hijaz, as well as Sharif El Nashar, EL space NASHAR, Nashar. And both of them are kind of on the west side and on the southwest side.
Next question is, how do I stop cramping when I wear a pessary?
So if you're cramping with a pessary, it may not be fitted correctly. It may be too large. But secondly, it may have to do with pelvic floor dysfunction, and that the pelvic floor is spasming when it shouldn't. In that situation, again, that pelvic floor physical therapy is a great option. I would like to add, one of the things that I forgot to mention earlier is that with pessary use, one of the safest and best options to use in combination with a pessary is vaginal estrogen therapy. So vaginal estrogen cream sends many patients' tentacles up. Their antennas go up, because when it comes to estrogen, there is a clear risk of breast cancer, ovarian, uterine cancer, clot, etc. Now, what I can say from that very large WHI, that Women's Health Initiative study, is that there appears to be no increased risk of breast cancer recurrence, clot, etc., with vaginal estrogen therapy, because that vaginal estrogen really isn't absorbed systemically. So we use it in patients who are breast cancer survivors. We use it in patients who are actively being treated for breast cancer. We use it in patients who are on warfarin therapy, et cetera, because it acts to revitalize the vaginal tissues, prevent any kind of rubbing, irritation, abnormal discharge from the vagina. It can really help restore the tissues of the vagina. Sorry, that was a segue.
We have time for just a couple more questions. The first one would like to know, do you have to stay in the hospital for several days, or is it outpatient?
Great question. So when it comes to the surgeries, and I'll bring something to the sacrospinous ligament suspension, you're home the same day. Typically speaking, with the uterosacral ligament suspension, it's one night in the hospital, home that next day. The sacrocolpopexy, similarly, one night in the hospital, home the next day. And finally, with the colpocliesis, home the same day. Now, all of these surgeries involve that pelvic floor, and because we involve that pelvic floor, there is the risk of urinary retention. Okay, I didn't mention this earlier. It's a very low risk, and it's something that's very temporal. So after all of these surgeries, any physician will check that bladder to make sure that the bladder is emptying before you go home through something called a voiding trial. And in rare situations, about 10% to as high as 20% of the time, some patients may actually need to go home with a catheter for just a few days. And then at the end of those few days, you take the catheter out, you're fine. It doesn't affect the healing or the success of the surgery. But that's one other thing to remember about the potential of the post-surgery.
And related to surgery, one person is saying that their fear is being completely under anesthesia, which might lead to dementia. And they want to know if all surgery options are required going completely under. So if you want to talk about the safety.
So there are lots of different kinds of anesthesia. And it's more complicated than this talk than I can talk about, but there is monitored anesthesia, so twilight anesthesia. There's regional anesthesia, so like a spinal anesthesia. If patients remember having like an epidural during their vaginal deliveries, And there's also general anesthesia, and there are even different kinds of general anesthesia, both with and without relaxation of the muscles. So a Le Fort clopochiasis, this type of surgery can be performed under light sedation and a spinal, but a lot of it has to do with risk and benefit. The issue with regional anesthesia, with a spinal anesthesia, is the risk for hypotension. And that sometimes is a much higher risk than the risk of dementia or other complications. So with a sacrocolpopexy and with a uterosacral ligament suspension, those are two surgeries that require general anesthesia, require muscle relaxation in order to access these areas safely. Sacrospinous ligament suspension can be done with a mask in the mouth, so general anesthesia, but a mask in the mouth called an LMA, a laryngeal mask airway. And again, the Le Fort is something that can be done through a regional anesthesia, but generally an LMA with a lighter sedation.
Quick question, while inserting a pessary, is it okay to use KY jelly?
Definitely, 100%. So KY jelly is a water-based lubricant. It's very safe. It's absolutely fine. Again, like I said a few minutes ago, I prefer silicone-based lubricants. The great thing about silicone-based lubricants is that there's typically no preservatives in them. They're completely inert when it comes to tissues. They don't dehydrate, so they kind of maintain their slipperiness. They're very safe, but absolutely, water-based lubricants are very, very safe on all pessary products.
And last question, would a prolapse cause intense pain with sexual penetration?
So no,
this is a lubrication issue, it's a postmenopause issue.
Yeah, so exactly. So there are many reasons to have pain with intercourse. Number one is dryness of those tissues, atrophy, that the tissues themselves are very thin and sensitive. Estrogen, we've got to rejuvenate those tissues. Number two, it can be the position of the uterus. So sometimes people will talk about, oh, my uterus is tipped backwards or tipped forwards. With penetration, if the penis hits that uterus, the uterus can kind of cramp and can give you discomfort with deep penetration. We talk about just getting in a different position, if that's the case. But most importantly, the thing is to make sure of is that there isn't dysfunction of the pelvis, that those muscles aren't painful. Because prolapse, again, shouldn't cause pain. It can cause pressure, it can cause pulling, but it shouldn't make intercourse uncomfortable. What happens is that you can have prolapse, you then consciously or subconsciously are trying to kind of hold on to that pelvic floor. The pelvic floor can spasm and become uncomfortable, and then that causes the pain with intercourse. Physical therapy.
All right, we know there are more questions, but I apologize, we're out of time. We could probably go all night. Dr. Henderson, can you put up your last slide again?
Oh, yes.
So people know how to contact you.
Yes, there we are.
So if we didn't get a chance to get to your questions, please feel free to reach out, schedule an appointment. Dr. Henderson would be happy to see you or one of our other colleagues. Again, for anyone who joined late, this talk is being recorded. It will be posted on the website. And for everyone who registered, you will receive that link to go back and watch this talk. Any closing words, Dr. Henderson?
No, thank you all for your time and your interest. And the idea is to be well and to be active and to do the things you want to do. So especially in COVID, this is should be about you. So let's get you feeling better.
Thank you all for your time tonight. We hope you enjoyed the talk, and we look forward to seeing you again.
Thank you. Good night.